Well, good morning. To kick off with our weekly Wakefield Orthopaedic Clinic weekly webinars. The plan is to hold these between 7:30 and 8:30 every Wednesday morning. They're going to arrange topics, and the actual topics will be available online at our clinic website, which you can see there at woc.com.au. These webinars are designed primarily to provide an educational update for GPs and to cover a range. Looking at shoulder pain, this can be the result of a variety of conditions, including referred from elsewhere, other causes, cervical neck issues as well. So basically, it's really this group in the 50 to 70-year-old where a lot of the shoulder pathology occurs. Rotator cuff tendonitis. This is the group that probably we see most of our work, particularly for shoulders. Arthritis, septic arthritis. Don't forget in the older patient, old dislocation, old injuries which sort of accumulate over the years, and fractures. Specific history. I won't belabor this, but there's been a specific trauma that's important. How long, the pattern, occurrence, general health, and of course examination is very important, particularly for certain very important customers such as this. Tenderness, deformity is important, wasting, crevitus, range of motion is particularly important, both active and passive. Often patients are told that they've got a frozen shoulder when in fact their passive range of motion is actually normal, but because of pain they can't elevate it. So this isn't a frozen shoulder, this is just specific lack of motion because of pain. We've got strength is important and also special tests, and I think there are three particularly important things to look at, both passive range of motion, the strength in particular, the rotator cuff, the external rotators, and also posterior capsular tightness is important. I think the next important process really is to get an X-ray. I mean, basically, I see a lot of patients who come on with basically an ultrasound first, and I'll mention that in a minute. But an X-ray really is the next big step, and very frequently this nails the diagnosis that you've probably already made. We can see here there's a normal X-ray which you would see perhaps early cuff disease, frozen shoulder. I'm not sure how well you can see it, but you can see under here there's a small lip, inferior margin of the glenoid. This clearly has an instability. So you can make the diagnosis just from the plain X-ray. This young patient has had a dislocation with some secondary changes related to instability. So you don't need any high-angled investigation or similar, but this will tell you what's going on. This patient needs some mild changes, some change of the greater tuberosity. There's a few mild, very, very early arthritic changes, maybe a little bit of prominence of the acromion. Again, you'd see this change in an older patient with cuff disease or tendonitis or something similar. Again, you can make the diagnosis on that, just about. Then the next X-ray, loss of joint space, obviously osteoarthritis, rheumatoid arthritis or similar, maybe cuff tear arthropathy or something like that. But again, the X-ray allows us to make the diagnosis in most situations. And then of course, the real thing which we do very unfortunately occasionally see is patients having had multiple ultrasounds for shoulder pain. In fact, what they had was a nasty tumour all along, which would have been found right at the start if they'd done an X-ray. And I think one of the problems we have now is that there's been a big push to do ultrasound for just about everything. And I think ultrasound really should never be the first investigation. Virtually, I just can't think of any indication where maybe a glomus tumour on a finger is where it's an excellent investigation, but that's about it where ultrasound really should be the major primary investigation. You know, cuff tears are common, so finding a cuff tear with an ultrasound really isn't a big deal, and it'll miss arthritis or tumours. So what an MRI, when do I do an MRI? Well, I really only do an MRI when I have a specific question that needs answering, either to show the patient what the damage is or to assess it pre-surgery, or if I'm really confused about the diagnosis. And it's usually to either exclude or confirm what's needed. And so we have 3 examples here, or say 2 examples of a large cuff tear. So clearly the cuff tear was evident clinically. This wasn't the diagnosis. The diagnosis wasn't made from the MRI. What I looked at was the size of the tear, the quality of the muscle for planning for the surgery, with the diagnosis already made. So the MRI didn't make the diagnosis. It just helped me then plan exactly how bad it was and then what treatment. This girl here, she's about 30. Symptoms again, probably some sort of labral tear. She fit in very nicely in the category of likely instability or rim tear. She's got a superior labral tear on the top of this middle picture you can see in white with a small associated cyst. And so clinically she appeared to have a superior labral tear, and the MRI then confirmed it and excluded anything else serious. So the main sort of topic today, which is really rotator cuff tendonitis and tears. This is the sort of classic customer, the 40 to 70-year-old, often a short history of aggravation, but often longer, a painful range of motion, often positive impingement sign or pain on forward elevation in the front of the shoulder, particularly if resisted. They're often weak next to the rotation, particularly with the arm by the side. X-ray is often quite normal, or will show some changes of the graded tuberosity, which would indicate a longer-term injury and some of the changes. And this really annoys me when I guess my registrars or other doctors ask me, how do you treat your cuff tears, with physiotherapy or repair? And I think the reality is that there's a staged management, because the majority of tears will get better. And those that don't need an operation, which I guess is good for surgeons, but the majority of tears are often asymptomatic. And this is just a bit of a sort of snapshot of some of the background data, in that rotator cuff tears are extremely common, and they're usually painless. The vast majority are painless and a coincidental finding. You'll often find a patient with a tear on one side that's painful and a tear on the other side that's not painful at all, and there's no consequence. And this is pretty common. There's some pretty good data in the US about the incidence of cuff tears, which are very common in 60-year-olds. And about 20% of those tears, generally, this is a bit of a big guess of course, will develop pain. And so about 20% of the tears are actually symptomatic. So the majority are basically asymptomatic. Of those 20% that get sore, roughly 50% will get better with the right physio or rehab program. And so just finding a tear really isn't an indication to proceed to surgery, although some will clearly need it. So really, overall, about between somewhere between 5 and 10% of the cuff tears. Question, Chris?
Yeah. One of the issues I have is accessing the correct physiotherapy plan, because I guess it needs to be regular and longer, a bit longer term than most of my patients can afford.
I think that's true. I think a lot of the physio, and I'll talk about that in a minute, but a lot of the physio needs to be very specifically targeted. In fact, the sort of typical patient that I would see with the cuff tear may need 3 visits with the right program. So a lot of the machines, massage, dry needling, flexion exercise, they're all, I think they're not targeted to the problem. And right. I'll refer you to the bottom of the page of the Wakefield Shoulder Clinic. There's a website which goes through the sort of philosophy on now obviously these sessions are designed for spruiking and sharing the love, so to speak. But nonetheless, I think we should be looking at good outcomes and good treatment, and then if the patients come our way, then all the better. I think that you're quite right. I've seen patients who've had 6 months of physio, lots of visits, spent a fortune, and are no better. And I think that's actually not uncommon. Now, obviously, I see a selected group of patients that come along after they've had some sort of average treatment, and so that can be an issue. But I think we'll cover this question again shortly in a minute, right? So, as I said, there's only a small number that probably need repairing. I mentioned there that steroids are bad. With steroids, there's really no evidence they're effective. Now, I get a bit of an attack from both both GPs who swear by them and also radiologists, of course, who live by them, so to speak. There really is no evidence that they work. They're short-term only, and they actually cause tears. There's about a 20% reported incidence of tears going from small partial tears to full thickness tears with steroids. So they actually soften the tendon, and that's not such a good option. They actually double the complication rate as well. So if you have a steroid injection, your chance of infection or cuff failure actually doubles if you have an injection within 6 months of the surgery. So they're not a good option. I mean, and just to reinforce that, the Cochrane collaboration, you've probably heard of the Cochrane reviews. There's really showed no long-term benefit, and it's really unclear if they're any better than anti-inflammatory or anything else. There's some other studies where they biopsied cuff repairs, and they showed actually there was loss of cells in the repair site because of the steroid. So it seems to often break down the tendons. It increases the rate of rupture. As I mentioned, doubles the complication rate. So they should really only be used in very specific circumstances when either a shoulder is very sore or the patient's not coping. And I think they can do potential harm, but enough of that. So the issue we have in this cuff tendonitis or cuff impingement or whatever is this impingement between the humeral head and the acromion on forward elevation and use. And under the effect generally the deltoid, usually in forward elevation as the shoulder elevates, the deltoid works, pulls the humeral head up, and you get this impingement. Now, and the reason you don't normally is because we have the downward effect of the rotator cuff, and so there's this fight between the deltoid pulling it up and the cuff pulling it down, and so it's got to be sort of in balance. And this will come to our discussion on the importance of the physio in a minute, Chris. So it's through this jamming here, and this jamming here can be due to three things. If there's an inadequate space up here due to either thickening in the bursa or spurs or even a cuff tear which is irregular, then this can cause catching and jamming. The main thing I see, and I'd say almost nearly every patient that I see with some sort of tendonitis or cuff have got this weak rotator cuff. Their infraspinatus is weak, it's not pulling the shoulder down, and so when they lift their arm under the effect of the deltoid, it actually causes the jamming against the humeral head, which then compounds it by actually damaging the cuff even more, which then again leads on to more cuff dysfunction and more this sort of positive feed forward. And this is at the heart of the sort of rehab program, which I'll get to in a minute. If the posterior capsule is very tight, this can cause catching and jamming. And sort of hinging as well, obviously the shoulder blade isn't positioning the shoulder well. I think this is probably the lesser important, but of course therapists like to maintain shoulder stability through the scapula. But I think in reality, the weak cuff and probably some posterior tightening is the key initially. And if this is fixed, then increasing the space is probably appropriate of the surgery or otherwise. I think it's also important to understand that impingement doesn't equal surgery, and I mentioned that conservative treatment will settle a whole range of shoulders. About half of them will get better with just a rehab program, as I mentioned, but it can take 2 or 3 months, perhaps 3 months sometimes. And many patients will still need surgery, but they'll be a lot better off having a shoulder that's mobile and strong to start off with. This is an interesting study which has caused a certain amount of dilemma in the surgical world. This is an English group who compared the physiotherapy with decompression and physio and cuff repair and physio. In fact, at the end of a year, there was no difference in the outcomes, which you sort of wonder what the point of the surgery is. And I think this is a good sort of wake-up call for us for those patients who are being funneled inevitably towards an operative repair, in that I think if you look at the whole groups, there probably isn't much difference because many will get better without surgery and many will not need surgery. And so if we can go through a staged management process and select those who fail the rehab program and then select those for surgery, then your overall surgical numbers are going to go down, but those who need the surgery will do better overall. So I think this is on the website that I'll show you again in a minute. Most shoulder pain, early surgery is infrequently needed, and if using the correct rehab. So when is surgery possibly required? Well, clearly if there's a displaced fracture, if there's dislocation with an unstable joint, if there's a massive sort of sleeve fracture, and this has got to be really massive, like the shoulder's almost sitting down by their lap, not just a large tear, and tumours obviously early reviewed. So there's very few that need to be urgently taken to surgery. Early surgery, maybe in about a month or so. We'll just make sure there aren't any another participant. I'll just let him in. Early surgery, maybe within a month. For subscapularis tears, big subscap tears don't tend to do very well if just with the rehab program. If there's a really large tear that's just got severe strength loss or major strength loss, and these probably do well repaired at about a month or so, would be my practice, certainly not straight away. And I think if they've done a rehab program and they're not making good gains in terms of strength, then they probably have a large tear and need this fixed. I'll just make sure that everyone's on board here. Yep, good. Okay. So who doesn't need early surgery? Well, I think, or early urgent surgery. Well, I think acute partial tears don't need urgent surgery. I think acute on chronic tears can sort of go through the right rehab program and not need urgent surgery. Long-headed biceps, again, often not needed at all, repairing those, but no rush. Those who haven't done the rehab program, so no rehab program, probably no surgery. The frozen shoulders will get better in time, may need a release later on. Calcific tendonitis, again, can wait and will do better, often delayed, and arthritis. If they're not getting better, they'll probably need some sort of intervention, but there's no urgent need to rush into, and it's better to look at some advice and some management pre-surgery. And as I mentioned, the majority of impingement is related to poor cuff function or cuff imbalance. Ultrasound investigations are often fairly unhelpful, as they'll show cuff tears in patients who frequently have tears anyway. Investigations are really no match for careful examination and clear thought. And I think steroids are rarely of any lasting use and actually can cause trouble. And certainly supraspinatus tears are very common. And often we see biceps subluxations, which really I don't think mean much at all in many situations, depending on the presentation, but certainly no cause for panic. So as I mentioned before, the stage management in rotator cuff tears or in tendonitis or whatever, I think is history examination first, really sort out what's going on, make a proper diagnosis, appropriate investigations as need be, and that includes ultrasound as well, and maybe even an MRI if you're not sure, but certainly good examination, history, plain x-rays, and then and the key is to restore the cuff strength, and usually as part of your examination you've found that they've got a very weak cuff with the decreased mobility. And then, Chris? Yep.
Sorry. Yep. Of the 20 or 30 different shoulder tests with relatively poor sensitivity and specificity, yep, which ones are your go-tos?
Well, as I said, it depends on the age of the patient. When the patient walks in the door, you've probably got a fair idea of what's wrong with them. So if a patient walks in and they're sort of a mid-50s, shoulder pain, then I want to know the active and passive range of motion. I want to know specifically the external rotation, and really it's actually this rotation right by the side here, not out here because this brings in deltoid. It's actually here. It's very important to examine them here, power, not here, because this brings the deltoid in. So ER power is extremely common, weakness is extremely common in cuff tendonitis. And things like O'Brien's sign, which is this one across the chest here, or there's the impingement sign here, resisted upward elevation. That's a good sign for impingement. If that's normal and the patient has pain here, then this would suggest a superior labral tear, the O'Brien sign. You see it? Now, I think the O'Brien sign is completely unreliable if they've got a positive impingement sign. So if they're normal here and they're sore there, then I think that improves the sensitivity of the O'Brien sign. There's Jurgensen's test, there's Speed's test, all sorts of tests for the biceps. So there's a whole, the various provocation tests, the other instability tests. There's a whole range of tests. Basically, what I look at is, in a quick screening, impingement, external rotation. If that's normal and younger, the O'Brien sign. Lift-off tests. There's the subscapularis test. You're aware that you've read the subscapularis. I think this belly test is the important one. Holding this hand on the stomach, bringing the elbow forward, and then trying to resist the lift-off of the hand. If that's positive, that's very highly suggestive of a subscapularis test. So if a patient came in to see me with shoulder pain, a positive lift-off test, I'd say, listen, I think you might get a subscap tear. We'll do the rehab, get your shoulder stronger. If it's not doing well in a month, we'll get an MRI then, and that will probably confirm a subscapularis tear. And you're probably not going to do that well with rehab. So you're the patient that probably we should be maybe looking at about a month or so to repair if they're symptomatic. Particularly if the mechanism injuries, for example, a traction injury getting out of a truck. I saw a guy yesterday who was getting out of his truck, traction injury, subscap tear, came along, did the rehab, got stronger, positive. It's called a belly lift-off test. There's also behind your back, where the shoulder, you hold the arm behind, so the infraspinatus, the subscapularis rather pulls the shoulder in, and behind the back lift off. If you can't do that, that suggests the subscapularis as well. So, I mean, you asked the question, any particular test you had in mind or you were particularly worrying about?
Not really.
Does that make sense? I mean, often you can make a diagnosis pretty quickly. If they're positive impingement and they're weak and they've got a normal belly press, and you think they're this sort of cuff tear type problem, then they need some cuff strengthening as the first stage. And you've sort of made the diagnosis.
Well, that's going to be the vast majority of my patients.
That's right. Anyway, okay. So, but those that don't achieve sufficient improvement in their outcome following sort of stage 3 may need to go to stage 4. And I think the key is this external rotation strengthening. And the TheraBand are okay, but if you do the TheraBand out here, you're basically bringing in deltoid. Doesn't work. You need to bring it in very close to the shoulder, like as you can see in the middle diagram there. And we've started using it really from there. This movement here, not out here, actually from here. And what this does is isolates infraspinatus much more effectively, and takes deltoid out of the action. Because if you're actually exercising and recruiting deltoid, then you're going to finish up with an imbalance. Posterior capsular stretching as well, but this is the sort of the TheraBand process that the patients that I would see, I would send them to certain specific physios. They would start this program here with this strengthening program, and that's all. No flexion exercises, some posterior capsular stretching, and that's about it. Nothing else, no flexion exercises, no machines, no needling, just this program, because if these are the mechanical deficits your patient with impingement's got, then this is what they need to deal with.
Just going to say, I think you find out pretty quickly, Chris, whether a patient's going to see the physio and getting a lot of machine and massage and needling type treatments. They can be good adjunct, but they really need to have a exercise-based program. That's really what we would see working. So, like Michael's saying, isolating certain muscles into the shoulder and really working on a dedicated exercise and strengthening program is probably going to give them better results than spending 30 minutes sitting in a chair with a machine attached to them. So I think once the patient comes back and you give them a quick quiz of what exercises have they been doing and what program have they got at home, you'll get an idea as to whether they're getting good programming or not. And it tends to be a bit of a trial and error program, I think, a process, I think. And it's even for us, we'd have a chat directly to the physios, perhaps writing the program of what we would expect the treatment to look like, and then seeing how that goes.
So this is really a page that I set up some while ago to try and sort of bring this all together as a bit of a sort of process. And I'll go straight to the shoulder program, because basically we talk about flexibility, good strength, and subacromial space. Where do you start? Really, some of the stuff is actually talking about what I'm giving in this talk as well. There's some good evidence from the radiology, sort of big crowds, that X-rays are the first stage, so that supports the no ultrasound first up. I've mentioned again on this page steroid injections, which are not that useful. Strength testing, and what's fascinating, this is some EMG stuff, and the reason why some of the physios we work with and we've talked to, we can sort of justify a bit what we actually do is, I'll just make sure everyone's on board here. Here we are. We had these patients who were doing the TheraBand exercises, and they just weren't working. We weren't getting good responses to their shoulders, and we couldn't quite work out why. And so we did a whole lot of studies putting EMGs on the various muscles. And so in this diagram in the middle, you can see that clearly? Anterior deltoid, middle deltoid, posterior deltoid, and infraspinatus. And so what we did, we put basically, this is EMG sort of recordings from each of the particular muscles doing external rotation. And so when you external rotate, as you can see here, testing it, some anterior, some middle, and some posterior, and quite a lot of posterior deltoid, and some infraspinatus. So this is essentially a normal shoulder. What we found is that by keeping the arm by the side, and I use this strap quite regularly, you can actually use your hand to sort of keep the elbows into the side. You can sort of hold it there and sort of crank it in. If you allow the shoulder to come out, they tend to sort of bring in delta, which makes them artificially stronger. But with this strap here, and just a belt or anything, just to hold the elbow by the side, what we did then is tested their strength and tested their EMG response if we're testing just infraspinatus and isolating deltoid. And if you look at that, that may be a bit small. Is that big enough on the screen? Can you see it? So this is the strength testing with the patient with a slightly abducted arm, and this is only maybe 5-10 degrees, so you would hardly tell it's right out. And their strength was 20 pounds. And we can see here that they're bringing some middle deltoid, some middle deltoid, some posterior deltoid, and a bit of infraspinatus. If we strap the arm by the side like this, and this patient had some mild symptoms, their strength halved. So she clearly has weakness of external rotation. And if you look at what muscles we're recruiting now, it's not much deltoid at all, but it's all infraspinatus. So this is actually isolates infraspinatus. And I love this patient here. We've probably got some time, so I'll show this little video. Let me know if it doesn't work. This guy came in having done some physio in a bad place. That's a bit unfair, but say a bad place. And he's 6 months of pain, told he had normal strength, and he's actually got pretty good strong. If you examine him, and he's actually fairly strong. One of my American colleagues said if you put $20 under their arm, that holds the arm in. I happen to have a Peter Jackson one, and he is quite strong. So with the note under his arm, as you can see here, he's still quite strong. If, however, you put a strap on there, and this really isolates infraspinatus and just takes away deltoid very effectively, and you test left first, quite strong. Test his right one, quite weak. So by basically excluding deltoid, and the reason for this, I think, is that when the patient actually holds the note under their arm, they actually recruit posterior deltoid. They're actually using deltoid to bring their arm into the side, and deltoid is actually in parallel with infraspinatus. And so what we're testing there is actually his posterior deltoid as well. Under there, still quite weak, still quite strong rather. So I think actually putting a bit of paper under the arm doesn't actually work, because I think what it does, it recruits posterior deltoid. And in fact, we've shown on our EMG stuff that this actually is relevant as well. So it makes it obvious. So these are the various management stages. So if I won't belabor this, but this covers a lot of the stuff that I'm giving in the talk. It's at you can see the website address there, Wakefield Shoulder Clinic. Pretty tricky to remember. The other thing that's of use in this particular website is some resources like Dr. Facts. It talks about some of the stuff I'm talking about instances of cuff tears, various other issues. And if again trying to make the case and understand what the situation is, if you go to some, for example, treatment stage manner, go fact check, it'll take you to another page which has a range of published data which talks about the various randomized trials, various trials to try and provide some evidence based on some of these treatments that I'm talking about. So that becomes a much more I guess evidence-based approach. So just to finish off, just a few case examples. This is a patient with 46-year-old, 2 months of pain, full range of motion, painful arc, as I said before, positive pinwheel sign, weak ER. And so this is the patient that you're talking about. He comes to your door, probably has an ultrasound, partial tear. Where do you start? Well, the X-rays look pretty normal. There's maybe some more hardy that. I'd say these are pretty much normal X-rays, which is what you often see in these patients. So the approach this patient would have in my practice would be this targeted infraspinatus testing. You can either give it to the patient themselves, but it takes a bit of time to make sure they understand it. But what I would normally do is send it to a particular physio. And again, there's a few dotted around the place. I use the guys downstairs here. They're also at Dulwich. There's this Heather Peters out at Golden Grove. There's a few dotted around the countryside, one in Penola, one in Port Lincoln, one down the bay. Hopefully this sort of Wakefield shoulder program is getting out, and I think if you'd have a let's say a trainable physio who you can share the love with and sort of explain the mechanics. And I think one of the advantages of that particular website is you can actually, if you're interested, go through that and say, listen, this is the evidence that actually it works, or what we're trying to do. And the downside of this sort of fairly simple physio program is it's not very exciting. And the patients go, well, I paid all this money and all he did was just give me some exercises and that's all I did. And that's all he did. And I said, well, is your shoulder better? And they said, well, my shoulder's fixed, the pain's all gone. I said, well, maybe that's relevant. So basically this sort of patient, usually they get their strength back by 2 or 3, often 4 weeks. They get back normal strength, impingement improves, they're sleeping better, pain's basically gone by 2 months in this particular patient, and they're discharged. So about half the patients I see at least would actually have this sort of program. So and this weakness of external rotation is really common. Second patient, so any questions on that at all? No. Okay, second patient on that, same sort of scenario, still weak ER, partial tear. Again, X-rays are a little normal, or there may be some minor change in the grade tuberosity, maybe a few more, but again, often not very much. Again, the same targeted exercise program. But although the strength came back in about 4 weeks, had ongoing impingement, getting more painful under load, still painful. And I think the problem now is if you look at that sort of triumvirate of issues, lack of strength, lack of flexibility, lack of space, the strength's good, the flexibility is good, there's lack of space. And so surgically, this patient needs to have a bigger subacromial space. So this is the sort of patient that at absolute minimum, I would go in at maybe 2 months after a proper physio program and consider a decompression, because basically their problem is not strength, not weakness, but actually lack of space. And often these patients will get worse with the physio program as they continue to, I guess, develop a fitter shoulder. So, and these do really quite well with the decompression, because basically they have a fit, healthy shoulder, fit and mobile. Impingement has been addressed by their balance of their muscle power, and you make more space, and they often proceed quite quickly. In fact, I was going through my cases last night to try and find a few examples, and really this is actually a very uncommon part of my practice. I see very few patients like, well, not very few, see relatively small number, but because most of them get better with the right rehab program. So another patient here, again, similar sort of story, a bit weaker, maybe some more changes up here as well. The exercise program is going, but really, although strength improved, ongoing impingement, catching, not happy, sleeping poorly. In this sort of patient, you might want to get an MRI scan to see really what's going on, because the ultrasounds had subacromial crepitus as well, suggesting a cuff tear. And this is the patient where an MRI, I think, is quite helpful to see really what's going on as to whether there's a cuff tear. And this particular patient is likely to have a cuff tear, as you can see on the right, so retracted. They've done the exercises, they've regained the strength generally, but they're still catching and jamming because of this irregularity secondary to the cuff tear. So this is the patient who would do well with a repair, potentially. Again, cuff repair was repaired at about 2 or 3 months post-review, sling for a month, good at 3 months, then back largely to normal by 6 months and getting better out to 12. So these are 3 patients often which have been with very similar approaches, but with increasing amounts of pathology and different responses to the initial management, each of which was correct initially, but then they go on. So I don't know whether you're interested to do it. Also, this is a little video of a cuff repair. Have you seen many cuff? Do you want to see that? I guess an audience of what? So this patient here, as you can see here, so the humeral head's to the bottom. That's the cuff tear there. You see that? That's pretty obvious. So what we want to do is basically put stitches through the tear, as you can see here arthroscopically. The grade tuberosity is down to the right. You can see where I want to stitch it back onto the grade tuberosity. We use these very natty suture passing devices to put stitches through the tendon, as you can see here. I'll sort of speed this up pretty much. We then take the tendons into the bone to secure it with anchors or some other way, and you can see the tendon now brought back onto the bone. We put a second one in there. We interlock the sutures. Okay, I'll just go back one. We then put a second suture in, as you can see there. We then interlock the sutures, as you can see, and then pass the sutures into the bone. And I think that diagram shows that the sutures into the tendon and coming out through the bone, and then secured with this little anchor out laterally. And there's the tendon going back on the bone where it's held to allow it to heal. So this provides a nice secure. But this patient has had maybe 2 or 3 months of rehab. He's got a fully mobile shoulder. All the other muscles are nice and fit and healthy, and so they're starting with a sort of full pack of cards before they go into lockdown with their shoulder in a sling for a month. And these patients actually do really quite well. It's slow, but they get a nice repair and they finish up with a good outcome in the vast majority of cases. Any questions on that? Oh.
No, okay, fascinating, Michael.
Second?
Fascinating.
Oh, David,
I haven't seen that before.
Okay.
Okay.
Okay. So, any questions on it at all? I can go over it again if you like, but I think that's hopefully obvious. This will be recorded, hopefully, this session. So here's another patient, again, 47-year-old, same sort of age group, 2 months of worsening pain. What's more important in this particular patient is a lack of forward elevation. So really only 40 degrees of forward elevation, no external rotation, but normal power. And this is about the very, very uncommon, pretty uncommon sort of true frozen shoulder type patient with again, fairly normal X-rays, gross global range of motion, but good power. So the cuff's working okay, it's just not moving very well. Again, the ultrasound came along showing limited range of motion, and the diagnosis in this situation is really a frozen shoulder or adhesive capsulitis, which in pure form are actually extremely uncommon. General motion, again, the idea is to maintain their strength. They've got good strength, but just a gentle exercise program to try and keep the strength, but not push the shoulder because it doesn't want to move. And this is the group that's really frustrating. And I think we don't have a good answer for these patients because they generally get better. The natural history of a true frozen shoulder is full recovery. This particular patient may maintain their normal strength. Their motion gradually recovered over 5 months, but they've been pretty miserable for 4 or 5 months. But the downside is that these patients really can't justify doing an operation that's unreliable and fairly unpredictable if the natural history is that it gets better. Now, maybe at 6 months you might think about releasing them, maybe a little earlier, but these frozen shoulders almost always get better, and there's been multiple long-term reviews showing that they actually get better. This patient, basically by 6 months, it all settled down. David?
Thanks. Hydrodilation. I've got 2 patients with frozen shoulders. I haven't seen any for ages, and 2 within about a month or so, just recently. Don't know if it's because of the lockdown and people have been trying to treat themselves or what, but
hydrodilatation, yeah, I think it's interesting. I'm not a fan of the hydrodilatation at all. I think what's interesting, if you look at the facts or the theory, or try and look for the evidence to support the whole process, the theorists would say that you have this shoulder that needs a hydrodilatation that resolves the problem, and the aim is to put in 60 to 100 mils of fluid, local anesthetic plus saline, and rupture the capsule. That's the sort of the theory on what you should be doing, or tearing adhesion within the shoulder. Now, the idea of actually doing that on a patient that's awake is just kind of crazy. I just can't. It just doesn't make sense to me at all. Certainly, you can blow the joint up, but there was the Victorians. There's a number of my Victorian surgical colleagues who are absolutely adamant that hydrodilatation is the best since sliced bread. And in fact, with no evidence to support it, in fact, when they did a sort of a randomized trial of hydrodilatation plus steroid, hydrodilatation without steroid, hydrodilatation and no hydrodilatation at all in a series of patients, the only patients that actually had any effect at all, and it was pretty minor, was the steroid ones. So the hydrodilatation itself had no effect at all. And the reality is, it just doesn't make sense to me. I think if you've got a frozen shoulder in that acute inflammatory phase, then I think intra-articular steroids into the joint itself helps to settle things down as a sort of temporizing, because they need a break. But they don't. It doesn't tend to change the natural history. It just sort of settles things down. And I think if you're using intra-articular steroid in a situation of a frozen shoulder that's very inflamed, then I think you are providing some temporary and improved symptomatic relief without an anticipation that they'll get better necessarily, but without causing much harm. The issue I have with steroids in the subacromial space is that they don't work much at all. They provide maybe a few weeks of help, and if you're going overseas, or which you're not doing now anyway, but going overseas, then maybe 2 or 3 weeks of less shoulder pain with a subacromial injection makes sense or is of help. But it actually causes tendon weakening and causes tendon damage. And so I think as a treatment option, subacromial steroids, because there are other things you can actually do to improve the mechanics, is a much better option. In the frozen shoulder, I think intra-articular steroid is a good way to give a bit of symptomatic relief, at least temporarily. As far as hydrodilatation goes, it doesn't make sense to me at all. In fact, I had a patient who one of my colleagues saw as a second opinion, and he was almost aghast that this patient had a stiff shoulder after a cuff repair and wasn't having hydrodilatation. And so this patient the patient was quite sort of upset with what I hadn't been doing. And my colleague said that she must go to this particular radiologist who was excellent at hydrodilatation, and she had to wait, I think, 2 weeks to see him and then pay a fairly sizable gap. And he used 10 mils of local and a steroid for her shoulder. Oh, it was silly. And it was intra-articular of 10 mils, which is nothing. And he called it hydrodilatation. So A, the philosophy is wrong. B, the execution was wrong. And it's just silly. So, I'm happy to sort of to change my mind if someone can show me decent data. But I think hydrodilatation is just a temporizing measure, which makes no difference at all. And if you leave the steroid out, it does nothing at all. It just doesn't make sense. And even the studies that have been shown, they can't show you rupture at all.
Yeah.
Does that make sense? Or
it does. Thank you very much. It's along the lines that I've been thinking, but I'm glad to hear you say it.
I think one of the problems is that if you talk about a patient with frozen shoulder, they're the hardest patients to treat because they want you to do something. The natural history is it's going to get better, and I guess what you can say to them is that if you do something and you manipulate them, you can fracture the humeral neck, which I've seen. You can fracture the glenoid, which I've seen. they get better temporarily with the manipulation, then they get worse again. And they generally join the sort of pattern they were going to develop it long term anyway. So it makes it pretty frustrating. So, and I think that you sort of almost have to do something at 6 months if they're just not making progress, even though the natural history still is they'll probably get better eventually. I'm not sure what you experience out in GP world is, but these aren't patients that really. Well, the fact that the true frozen shoulder is quite uncommon anyway, and most of the frozen shoulder or so-called frozen shoulders, I think, are very irritable shoulders from cuff dysfunction and are sort of a form of cuff tendonitis, which can generally be improved with a very gentle stretching and exercise and strengthening program. So I think there are really very few true frozen shoulders that we might.
Yeah, these two have got extraordinarily little movement in both shoulders, but have had for several months.
Yeah,
I keep telling them that it's going to get better, but the other problem is that people want to go and see someone else just when it's starting to get better. So.
Yeah, that's right. Well, join remain part of the real world. I guess the issue, if you tell the patients about the sort of the stages, which I'm sure you're aware of, the heating phase and the freezing phase and then the thawing phase, and I remember a couple of patients who came to see me after I thought they might have had the early phases of a frozen shoulder because their exos were normal, their strength was normal, they just had a fairly stiff but very irritable shoulder, and they came along thrilled that the shoulder was getting stiffer because I explained the phases they need to go through to get to where they want to be. And they said, great news, my shoulder's evolving through these various phases. I'm on the way. So for a patient to come along and say that they're thrilled because their shoulder's getting stiffer was quite gratifying that they'd actually be listening to what I was trying to say to them. So I think, again, if you actually instill, I think what I think about treatment is often treatment is proposed in certainly surgery as being, can do no evil, and you must go ahead and do it because there's nothing to lose. Well, I think a frozen shoulder, if you actually manipulate a shoulder or do something and then scope it afterwards, it's just ugly. I've manipulated shoulders that I just could not get into after, say, 6 or 8 months and had to manipulate them before I then did a sort of scope, debride and release to try and do something. And they pulled a hole sort of about 3 or 4 millimeters of their entire anterior glenoid bone off with the capsule. Just pulled it all away, which is awful. And so what I then did was release the capsule and the labrum then sat back where it should, and so it healed quite nicely. And the long-term result was quite good, but these are very stiff shoulders, and if you start trying to manipulate them, you can do a lot of damage. And I've certainly seen one of my colleagues do a manipulation on a sort of older patient, and the whole humeral head crushed in. And she'd have been much better off just being left alone and allowing the shoulder to evolve. So I think some balance and management can be achieved by being sure of what you're dealing with: normal X-rays, normal strength, global loss of shoulder motion, maybe an MRI or something just to make sure there's not some tumor lurking or something really serious, and then understand the natural history and understand that. The natural history has been challenged many times and has been shown to be the same all the way through. But also, treatment, manipulation, releases, these things may not help much at all, but also may do harm in a condition that's actually going to get better anyway. And to suggest to patients that they may as well because there's nothing to lose is really not the case at all. So I'm not sure what you guys think about that, but it's pretty hard to have these patients. They take a long time to convince. And as you say, they go and see somebody else who does the manipulation as they're getting better, and they think that other surgeon's fantastic. But I guess what the best you do is not to try and treat them badly, just simply for to hang on to them. Questions?
Thanks, Michael.
Okay, all right. Okay, so we'll just finish off. We're getting close to time now. Just another case. This is a patient who, again, someone said along as tendonitis, often with an ultrasound showing small cuff tears. I know Chen's online too. He'll be giving the same webinar in a few weeks' time on arthritis. I won't steal his thunder, but this is a sort of patient, 65, a couple of months of pain, but getting worse over years. Lack of range of motion, good power, but the X-rays show spurs, lack of joint space. So clearly this is osteoarthritis, and treated most effectively by activity modification, analgesics advice, and if they can't cope, then a shoulder replacement does really very, very nicely in this sort of situation. So I think to finish off the take-home message, I think it's probably reasonable to over-treat some of these patients. I mean, I think if more patients get surgery than they need, that they would have got better. And I think frozen shoulder may be in this category because otherwise people go nuts if nothing's happening. It's probably reasonable to over-treat them to a certain extent, but it's got to be very, very measured in how aggressive you get, because a lot of these things will get better, and certainly the majority of small cuff tears will get better. The majority of tendonitis will get better with the right rehab program. there really is no clear benefit in surgically treating cuff repairs, and I think this is the overall group. It's a bit unfair to slam all cuff repairs, but if they're seen in that small group of patients that have tuned their shoulder up and haven't responded, then I think they do well with cuff repair. But overall, the group probably half didn't need it, and half, and many do. I think it's important that there's no difference between open or arthroscopic repairs. I think if we can do the same job arthroscopically as we can do open, then I think you can justify doing it arthroscopically. I've had a few issues over the years with the technical compromises required by doing things arthroscopically, but I think we've now got some good gear which allows us to do the same job arthroscopically as open. So I think we can now transition to a less invasive procedure, but without technical compromises. And I think what's interesting is that the cuff re-tear is very high, and what's been shown that going from open to arthroscopic hasn't actually improved the cuff tear rate. It's about 50% in some older patients, and while a lot of series quote much lower re-tear rates, there's still 30-40%, and it's kind of crazy that if you've got an operation you do and 30 or 40% of them are going to fail, but patients still do well, you got to ask, did it need repairing in the first case? And I think a lot of these patients who probably never needed a repair had a repair, it failed, and they still did well anyway. So it's a bit of a mixed bag of what's appropriate. However, it does appear that if you've got a big tear and it heals, you'll do much better, but it's not actually critical. So if you look at the evidence is somewhat confusing because it's a lot of spruiking, but if you look at the numbers, I think that a big tear that's catching and jamming does well with a proper repair, but the re-tear rate's quite high. And I think what's also quite worrying is that in some of the stories you hear is the progression to cuff arthropathy. So this inevitable arthritis that you'll get unless you rush in and have your cuff repaired straight away. I think this is just not true. The incidence of cuff arthropathy is actually quite low. Now, if you've got a huge tear, gross weakness, then your progression to arthropathy over about 4 to 5 years is about 30% or so. So in that's an extreme group with big tear, lots of weakness, older patients, they can develop pretty difficult to repair tears and secondary arthritis. But for the vast majority, the chance of getting arthropathy or arthritis that's unrepairable is just like, so, in the matter of a few percent points. And there's no urgency to rush. I guess the only urgency to rush is they'll go to see somebody else, as you said, and you'll find someone to fix it for them. So you really need to make the case for cuff tears. And I think a lot of these cuff tears, we actually repair tears that are causing catching and jamming in the subacromial space, not actually a mechanical deficit. So a lot of these patients that I repair have normal range of motion and normal strength, but they're just catching because the cuff catches. So we're actually fixing cuffs to fix catching, not actually mechanical restoration. In, I'd say, probably 2/3 of the cases. Some that remain weak have large cuff tears. They need to be repaired to get the muscle back onto the bone. But the majority of cuff repairs regain their strength. And I think you're really creating a smoothing of the rotator cuff in the subacromial space, not necessarily restoring the mechanical integrity. So I think we're just on time. The plan is to run these every week. It's not too intrusive for people like us getting up in the morning, and hopefully it was of some use. It'll be recorded so you can see it as well. There's actually a button on the home page which takes you to the webinars, and the log on will be from there. So as need be, and also the webinars will be saved as we go. So we'll go from there. So
excellent. Thank you.
On that note, any other comments, and I'll go and have my breakfast.
No, thank you very much. Very informative.
Good on you. Okay, catch you later. Thanks for dialing in.
Bye.
Yeah.